I will now proceed and introduce to you our guest speaker, Dr. David Michael Brandman. Dr. Brandman is a fellowship-trained neurosurgeon who specializes in helping patients with movement disorders, epilepsy, chronic pain, and spasticity. He is an expert in the use of neuromodulation and minimally invasive approaches that minimize side effects without compromising effectiveness. Dr. Brandman's research focuses on developing restorative neuroprosthetics to help people living with chronic neurological diseases such as stroke, spinal cord injuries, and ALS. He specializes in brain-computer interface technology, devices that record brain signals from people living with paralysis and translate their brain signals into commands that can be used to control objects in their environment. He is the co-director of the UC Davis Neuroprosthetics Lab. His research experience spans neurosurgery, computational neuroscience, and neural engineering. Dr. Brandman has published 24 publications in a variety of subjects and leading journals. He has written book chapters, been awarded numerous competitive research awards and scholarships, has presented dozens of abstracts at scientific meetings, and has been an invited speaker in multiple countries. He is active in medical education and public science research. Dr. Brandman's philosophy in working together with his patients and their families to make sure they're well informed about their condition and understand their treatment options. He cares deeply about making sure that his patients get the best possible neurosurgical they can. Thank you, Dr. Brandman, for being here with us today.
All right. Good morning and good afternoon, everyone. Thank you, Kelly, for that very kind introduction. My name is David Brandman. I'm a neurosurgeon and associate professor of neurosurgery at UC Davis in Sacramento, California. And without further ado, I'm going to go ahead and share my screen. All right. Can y'all see my screen? There should be a picture of a brain with my name on it. Excellent. Give a thumbs up. So thank you so much for the kind introduction and giving me the opportunity to present today. As you can see, I'm dressed in scrubs. I'm a neurosurgeon and I am in the operating room later today. And I'm really excited to tell you and talk to you about my passion, brain-computer interfaces, and more specifically technologies that have the capacity to hopefully restore communication for people living with paralysis. As we go through this talk, I'm going to be telling you a little bit about the stuff that I think about deeply on a regular basis. It's my research lab focuses on, my clinical interests. And then I'm going to broaden out with regards to the current landscape of brain-computer interfaces. I think the best way to approach this is just for me to speak. My lecture is about half an hour to 35 minutes long, and then afterwards to take questions at the end. I found that sometimes people will ask questions that I will tend to come to later, and so it's often helpful just to have questions at the end as we go. With that in mind, firstly, some disclosures to be aware of. I am the proposed study PI, which means I am the proposed clinician in charge of a future clinical trial put on by a medical device company called Paradromics. And I'll tell you more about that clinical trial as the lecture goes on. And I'm also an active consultant for a robotics company called Globus Medical. And it turns out that consultation has nothing to do with what we're going to be talking about today. So I run a basic science laboratory, and I'm a neurosurgeon. So Mondays, Tuesdays, and Wednesdays, and some Thursdays, as we can see, I specialize in help people with epilepsy and movement disorders, and I implant devices to help people living with medical conditions. But on most Thursdays and Fridays, I actually run a laboratory called the UC Davis Neuroprosthetics Lab, together with a basic scientist. And so we're both a surgeon and a scientist working together to develop technologies to help people living with paralysis. And the capstone project of my program is really developing brain-computer interfaces, or BCIs. Now, a BCI is a device that records brain signals from people that are paralyzed and then translates those brain signals to allow people to control objects in their environments. And my group is most interested in developing speech neuroprosthetics. In other words, devices that record brain signals and then translate those brain signals to have words appear on a screen to help people communicate. And what I'd like to do now, if you permit me, I have I just want to make sure that my audio is being shared. You are sharing sound from my computer. Perfect. What I'd like to do now is actually play a video for y'all. And this is a recent video of a clinical trial participant named Casey. And what I'm going to be doing is sharing this video with you, and then we'll spend the rest of our time together kind of unpacking the video that we just saw, talking a little bit about the science at a very high level. So y'all can follow the kind of some of the details we'll be talking about, and also discussing how this has impacted his quality of life and talking about the potential for this technology moving forward.
Not being able to communicate is so frustrating and demoralizing. It is like you are trapped.
Communication is so important to our everyday lives. Something as simple as, I have an itch, or I'm thirsty, or I love you. Imagine not being able to say those things to the people that you care about most in your life. A brain-computer interface is a device that records brain signals from people that are paralyzed and then translates those brain signals to allow people to communicate. So this research is happening as part of a clinical trial called BrainGate 2. The idea is people living with conditions like spinal cord injury, brainstem stroke, or ALS undergo surgical implantation of electrodes into their motor cortex. And thereafter, they work with a scientific team to develop next-generation technologies to help people living with paralysis. I recently implanted a 45-year-old man with ALS who really can't be understood when he tries to speak very easily. And by using a BCI, we can translate his desire to speak and have words appear on the screen.
In essence, what we're doing is we're bypassing the injury. We're recording from the source, from this part of the brain that's trying to send these commands to the muscles. And we're translating those patterns of brain activity into the phonemes, so that's like a syllable, the unit of speech, and then the words that they're trying to say.
Not only can we accurately decode the words that he's reading prompted off of a screen, but we can also accurately predict what he's trying to say in free-form conversation.
A lot of the demonstrations of BCI technology over the past few decades took weeks or months to get working. The first time he tried to use the system, it just worked.
Okay, ready?
That first time that he tried to speak and that word appeared on the screen, he started crying, I started crying, his family started crying. Basically everyone, we had to pause. We stopped the rest of that block of experiment trials. Everyone composed themselves and we're like, all right, let's do it again. And it kept working. So yeah, it was really special. It was a special moment.
At this point, we can decode what he's trying to say about 99% of the time, which is better than a lot of commercially available smartphone applications that try to interpret your voice, which hover around 95%. This is by far the most accurate decoding ever reported, and it's also a demonstration that this just works.
So it's not that we're reading people's minds, we're not detecting their inner thought or their inner monologue or even their mind's voice. We're really detecting their attempt to move their muscles and to talk.
People who do not have the ability to communicate well or quickly are often isolated and lonely. Having something like this will give them hope and opportunity to be more of themselves.
We've actually used artificial intelligence to mimic his own voice.
The easiest way to protect ourselves from mercury pollution is to limit our consumption.
By using video recordings that were collected prior to him having ALS, we were able to digitally reconstruct his voice. So now when he tries to speak, not only do words appear on the screen, but it sounds like him.
It feels a lot like me. It makes people cry who have not heard me in a while.
I think we're at a point where it does work well enough that it really lets people just be a part of society and to talk.
I am able to still work full-time for climate action, and I am able to do that well and more efficiently with this device.
Honestly, the reason this is so transformative is because it provides hope for people living with these kinds of diseases, that as they face their disease, that they know that they will hopefully have the ability to retain communication.
I hope that we are at a time when everyone who is like me have the same opportunity as I do to have a device like this that will help them communicate. Let's all make that happen, okay?
So I'm going to unpack a little bit of that video that we just saw, and then tell you a little bit about the clinical trial. And so BrainGate is a clinical trial that's been going on for the last 21 years that is setting the safety profile of chronically implanted electrodes in people with paralysis, like Casey. So while the clinical trial is really designed to study the safety of these devices that are implanted in the brain, as people enroll in the clinical trial, they actually work with scientific teams and engineering teams to develop neuroprosthetics. And the specific technology that we're using is something called a Utah array, or microelectrode array. Essentially what it is, it's a device that's implanted into the brain. And so as part of a neurosurgery, as part of a surgical procedure, I expose the surface of the brain and then implant this tiny array that's about the size of a baby aspirin into the brain, that's designed to record from individual neurons or individual nerve cells in the brain. And essentially, as someone tries to do something like speak, we can record the brain activity of someone trying to speak, and then information is then transferred over through a tiny little gold wire into a pedestal that goes and sticks through the skin of the participant. And the idea being is that we are actually recording the fundamental unit of computation or the fundamental neurons in the brain that represent motoric activity. So represent the action of trying to speak. And then we use sophisticated artificial intelligence algorithms to then take someone's brain signals to have words appear on a screen. Now, just to be clear, this is not a mind reading device. This system is not designed to get your deepest, darkest secrets, right? Instead, what we're doing is taking advantage of what we know about how the human brain works, is that it's decoding the attempt to speak. So that oftentimes in ALS, people want to be able to communicate, but their muscles just aren't working. The information isn't going properly from the brain to the muscles themselves. And essentially, we're bypassing that injury that people have with ALS to help people communicate. So this work was recently published in the New England Journal of Medicine, arguably the top clinical journal in the world, kind of demonstrating this one man's experience of using the BCI. And so on the right-hand figure, it's just recapping that we're recording these brain signals from these arrays, extracting the firing activity of these arrays, running them through a neural network or aspect of artificial intelligence to then predict which fundamental building block of language he's trying to say every 80 milliseconds, in which case a phoneme. So if I say the word hello, I can break up the word hello into ha, and o, and then I can use other artificial intelligence algorithms to combine those phonemes together to produce words, and then words that appear on the screen. So the surgery happened in 2023, and a few weeks after surgery, we arrived at Casey's home, and we just asked him to read words on a screen. And then after about half an hour or so, we flipped a switch where we turned on the computer program that actually translated his brain signals as he was trying to speak in real time. And when we first did that, we aimed low, in the sense we aimed to just decode one of 50 different words. And the reason for that was because the previous state of the art that was described in 2021 using a different kind of technology as a source of brain signals had demonstrated that you could get a fairly reliable decoding with just a limited vocabulary. And the very first time we turned it on, he started to use it, it was remarkably accurate. It was on the order of about 99% accurate. And so We were pretty excited. We came back 2 days later, and then we opened up the vocabulary, or we took off the training wheels, so to speak, going from 50 words to 125,000 words. Now, I'm a native English speaker, and I'm college educated, and I know somewhere around the 40 to 50,000 words. I don't know 125,000 words. This is effectively any word you could imagine and then more. And moreover, this is the kind of computer program that actually you can include new words, for example, proper names, profanity, and so forth, slang. And so the second time we showed up and we tried to use it, it worked about 91% accuracy. And so the accuracy kept getting better. And so here I'm just highlighting that the previous state of the arts up to this point with our colleagues at Stanford University had made the accuracy about 75%. So that means that 3 out of 4 words that are decoded are correct and 1 out of 4 is wrong. And the previous best with a 1,024 word dictionary using a different kind of technology called electrocorticography, which goes in the surface of the brain, was again around that 75% mark. And as Casey kept using the system, it kept getting better. So as the artificial intelligence algorithms had more exposure to what and got a chance to learn Casey's brain signals, it got better. And, we're a research laboratory, and we fixed some of our software bugs. We made some mathematical innovations at that time, and it kept getting better. And it's now hovering on regular use somewhere in the 95 to 99% range, ongoing use. So how quickly does he use it? Well, the answer is reasonably quickly, but not as quickly as I'm communicating to you right now. So a native English speaker speaks somewhere around 100 to 150 words per minute, depending on how excited you are. He's speaking on the order of 30 to 40 words per minute consistently. Now, what's important to recognize, though, this is substantially faster to his previous state of the art, which was using a gyroscopic head mouse or an eye tracker, a Tobii eye tracker, and also substantially faster than going through a skilled interpreter. In other words, having an expert care partner understand what he's trying to say and speak on his behalf. And I would say when I met Casey, I could understand maybe about 10% of what he said. And I think that I think that number is probably lower now compared to when I met him, but he's actually continuing to use this brain-computer interface. And so the structure of the clinical trial is such that we have our home base at a research laboratory. In our case, it's in Davis in California. And we actually go to the homes of participants, say 2 or 3 times a week. We arrive, we don the system, we turn on our computers, and then we start investigating what specific aspects of science or engineering we're trying to explore that particular day. We're usually there for 2 or 3 hours. Then we doff the system, we go home. And what we discovered within the first 200 days of working with Casey is that the system worked remarkably well. We actually petitioned the FDA to give us permission to train Casey's care partners to don and doff the system without us. And in so doing, he became a power user. And he has used the system for over 4,000 hours now. He uses it every day. He uses it for up to 19 hours per day. And in fact, he's actually gone back to working despite being tetraplegic, despite not being able to move his arms and legs, despite needing help for everyday activities and not really being understood when he speaks. He's gone back to work full time in this advanced state of ALS. And so he uses it to send text messages. In fact, I was texting with him yesterday about a medical issue. He uses it to write emails, to Zoom with colleagues, and so forth. And so this is a publication we've recently submitted to a non-peer-reviewed publication source, so-called bioRxiv, just demonstrating these results. And we've submitted this for peer review, kind of the gold standard of scientific publication quality recently. And we're hoping that we'll be able to tell this story. So it works pretty well. It's not perfect, but it works pretty well. And we've set up the system in such a way that he can tell us how well we've been able to decode what he wanted to say. So he'll say a sentence, 10, 20, 30 words or so, and then he'll push a button. And then he'll be able to evaluate what was decoded completely correct, mostly correct, completely incorrect, and were there any corrections made. So for example, if I'm saying a sentence that has 20 words in it, and instead of saying the word dog, the word cat comes out, well, we've actually built a user interface so he can go in and identify the word dog as wrong, click on it using an eye tracker, and then change the word dog to a cat. And then that mostly correct sentence becomes a fully corrected sentence. He can push another button with an eye tracker and then copy paste that into an email or you can push another button and have what the text that's written actually being spoken aloud into an AI-generated or machine learning-generated imitation of his previous voice. That's, in his own words, pretty good. So he's spoken about 183,000 sentences, and you get the sense here that about half of what we get, we nail. And the other half, we don't nail it right away. And sometimes he's able to get mostly correct through some corrections. And sometimes we just do a very poor job. And about 7% of the time, our computer programs fail to decode what he's trying to say. And all that is to say, the system's not perfect. But boy, it certainly has empowered him to be able to communicate more effectively. And he uses it as his preferred primary means of communication at this point. So everything I've been talking about now has been focused on decoding the intention to speak into words on a screen. But of course, as I'm having a conversation with you, I'm not speaking through text. Because everyone knows text messaging is a great way to miscommunicate your ideas and be misunderstood by your interlocutor. And so what if we could actually decode his intention to speak and synthesize his voice in real time? And this is new work that was recently published in Nature. I should say my postdoc, Nick Card, led the Brain to Text project, and my postdoc and now research scientist in our group, Maitri Wegrakar, led this work of actually real-time synthesis of the user's voice. So in the video I'm going to show you, you're actually going to be hearing Casey's synthesized voice as he tries to speak. So words are going to appear on a screen, and he's going to be trying to say those words, and we're going to be translating his brain signals into speech in a 25 millisecond delay, which is roughly the delay that my brain has as I try to say something and then sound is produced.
I will get there as soon as I can. I never want to know that there. I would love to meet your family.
Okay, so that was pretty cool. And I hope we can agree on two things. One is the voice is somewhat intelligible, right? So without that prompting, it turns out that people can understand somewhere between 50 to 75% of what's said. And it kind of sounds robotic. And so we have active research projects in our group. We've recently submitted grants to keep expanding that brain to speech, to take it from a somewhat intelligible, robotic sounding voice to hopefully something that has the verisimilitude of naturalistic speech. In other words, something that sounds human that you could use for everyday conversation. So this is the steps we're taking towards this. And, as I have this conversation with you today, this is not something that I can prescribe as a doctor just yet. So when I meet patients with epilepsy or Parkinson's disease, which is the bulk of my clinical practice right now, I can sit down with them and I can say, look, you have epilepsy. I have a device that can help you. This is the FDA approval for the device. These are the known risks. These are the known benefits. Here's what the literature says. Surgery scheduled for next week. And this is what, I've done X number of these operations, and here's what you can expect. And right now, when it comes to the modern era of implantable brain-computer interfaces, we're not there yet. Everything I've talked to you about so far has happened in the context of ongoing clinical trials that are designed to study the safety profile. In other words, ask the question, are these things safe for us to use in people with paralysis? And as you saw, there's something sticking out of his head. Right? When I implant devices in people with paralysis, implant devices for my clinical practice, the devices are fully implanted. And I think the good news is we're about 5 years out from getting to a point where a surgeon will have the ability to be able to prescribe a device for a patient. And I hope that conversation goes something like, look, Ms. Smith, I'm sorry you've been diagnosed with ALS. I don't have a cure for you, but at least I can have you communicating with your loved ones so that you can say, gosh, my nose is itchy, or I love you when you want to speak. I think we're knocking at the door, and I think we're knocking at the door because we're at a very exciting point where there's now multiple companies in this space that have either launched or plan to launch clinical trials that are studying the safety profile of their devices. And I've highlighted 4 here, and there are others. These are just 4 that are the most active in the game right now. And I'll unpack a little bit about the technology and where each one of these devices are. I should say, before I get started unpacking this, I am the proposed study PI for the Paradromics clinical trial. So Synchron has recently completed 2 of their early feasibility studies, a fully implanted wireless device to targeting people with paralysis to help people communicate. And so their system works by placing something called a stentrode, or a electrode that goes into a large vein in the middle of the head, and then recording motor activity from the brain through that electrode, and having the electrode come out through the vein underneath the skin into a battery or a transceiver that can then send information to a variety of computers to help people communicate. Neuralink, of course, is probably the most well-known nationally and internationally by virtue of some of the personnel who are involved with Neuralink's leadership. But they have developed a fully implanted system that has electrodes that are robotically placed into the brain very precisely, with the goal of recording not only in different areas of the brain, but different depths of the brain. And their early feasibility study is ongoing. They have no peer-reviewed literature so far, but boy, are they active on social media and have been, as far as I know at last count, and I could be wrong about this, they've had 9 people implanted so far with their device. And most of the focus has been on restoring communication through point-and-click communication and uses of other computers. And they've also opened up another early feasibility study targeting specifically speech, although they haven't reported anyone implanted along that early feasibility study today. Precision Neurotechnology is using a different kind of recording device. And so Synchron records from a vein near the brain, Neuralink records from within the brain, and then Precision records from on top of the brain. And their plan is, my understanding is, their plan is to, in the next few years, develop a device that is fully implantable, helping people with the goal of trying to help people communicate in the future. Right now, their testing is happening in the context of the epilepsy monitoring unit, or hyperacutely in the operating room, as surgeons use brain signals to help guide their surgical resection for a variety of conditions, most notably epilepsy. And then finally, Paradromics. So they are a device company developing a fully implanted device designed to record brain signals from within the brain of a form factor that is reminiscent of the Utah array, which is the technology that Casey was using, as well as another kind of technology I routinely use in my clinical practice called DBS, or deep brain stimulation. And so the idea is their system is fully implanted and has a series of modules that are implanted into the brain, carry information underneath the skin to a transceiver that's going to sit in the chest, that then beams out information through the skin to a series of computers that are going to be there doing decoding. Now, I mentioned that Neuralink has specifically opened up another early feasibility study looking at people with paralysis that want to speak but can't. And that is the primary focus for the Paradromics clinical trial, really focusing on speech restoration for people with paralysis, including ALS. So I want to close out this presentation by sharing some of Casey's words with you, and he's allowed me to share this with this group. What you're going to see is him speaking on in his own words, about how this technology has impacted his quality of life. The video is going to start out slow, and then it's going to fast forward through certain segments as he's speaking, and just pay attention to the fact that it says it's sped up, let's say 8 times at certain points, just because he's not actually speaking that quickly. He's speaking 8 times slower, but yet for the sake of brevity and for time constraints, we wanted to speed this aspect up to get his message across. This is a video that was originally recorded for us to communicate how BCIs affect people that we could share at the most recent International BCI Society meeting that happened in June in Banff, Canada. And I'm excited to share this with you.
It is also important for you to think about people like me, who cannot move almost any part of their body, even if it is impossible to truly understand what we are going through on a day-to-day basis. this decoder and technology is enabling me to do so very much and stay tethered to my life as a human being. It is sad to say that people in my condition are incredibly lonely because we are often shut out from society, because we do not move at the same speed as the case of everyone, and do not talk or speak at the same speed as well. Imagine that you have technology to be able to communicate, but it was only about 1/10 the speed of what a normal human would call. And then you will have this technology, which is enabling me to keep up with the flow of conversation if I am in polite company and people slow down just a little bit. This is enabling me to talk with my family and my friends and have a productive relationship. With my daughter, who is only 6 years old and does not remember my voice from before, this disease took it away. This device is approximately 5 to 7 times as fast as any commercial products on the market today, and enables me to keep my job as a person who, like you, is doing important work on the issue of climate change. This also enables me to have employment when I have a disease that is so incredibly expensive to care for and I am not bankrupting my family. It is so emotional to talk about this because this technology is everything to me. I want you to get working as hard as you can, but get this technology into people as soon as humanly possible. It will save people's lives and change people's lives. Your hard work is going somewhere tangible. And I encourage you to talk to the team that is at the conference from the University of California, Davis, to get their reflections about how their clinical work is making a human impact on someone like me.
So this work happens as part of a team. So I run a research laboratory together with Sergei Stavisky. And also we have a group of 4 postdocs, 4 Ph.D. students, 2.5 staff. We are part of an academic consortium called BrainGate, which also has clinical trial sites at Stanford, Mass General Hospital, as well as Emory. The clinical trial is still ongoing and enrolling. And so if you or your loved one live within 3 hours driving distance of one of those cities I mentioned, Boston, Atlanta, the Greater Bay Area, or Sacramento, please feel free to reach out find our website at braingate.org, and then let us know that you're interested, and our team will follow up with you just about the logistics and answering some questions you may have about the clinical trial. So with that, I'll stop here, and I'm happy to take questions.
I can read out from the chat. It looks like Joe had asked, first of all, are there any non-invasive systems that perform these tasks? And how does your fully implanted system compare to those?
Yeah, that's a great question. I'm glad you asked it. So one way to think about brain-computer interfaces as a category is to divide them between those devices that need surgery, that are implantable, and those devices that do not need surgery or not implantable. And I will say my personal bias and my personal experience comes to devices that are implantable, partly because I did my PhD and my postdoc in that technology, and partly because I do brain surgery for a living. But I will say, on the whole, the vast majority of work and research in this field has been done in non-implantable devices, or devices that don't need surgery. And I think the way that I've come to think about these two different kinds of categories of technology is really about answering different kinds of problems. If your goal is to have a device that will help you call out at 2 o'clock in the morning because you're in pain, you don't need the surgery, right? You probably just need an EEG or an electroencephalography device, or maybe an FNIRS device that can decode your, that can sound an alarm bell, for example, to get someone's attention 2 o'clock in the morning because there's a problem. But if your goal is to have a conversation with your daughter and tell them that you love them, a not implantable device can't get you there. If your goal is to have a meaningful conversation with someone where you can have a conversation with your spouse, or you can go back to working full time and communicate as eloquently as Case is able to do it, then the frank reality is you need this devices right now that are non-implantable just won't get you there. And so I hope that helps to answer the question. And I think that much like everything else in life, there's a role for different kinds of devices that are designed to solve different kinds of problems. And my focus and my emphasis is really on restoring naturalistic communication. So you try to talk and you can be heard.
Bill. Antoinette wants to know if there's any data about the longevity of the electrodes.
Yeah, that's a wonderful question. So the clinical trial is still ongoing. We've implanted, so there have been 21 people enrolled in the clinical trial so far, and it's going on for 21 years. We have a very good understanding of the longevity of these devices in animals, studied in non-human primates, and we're continuing to learn about the longevity of these in people. I can say the longest people enrolled in BrainGate have been in the clinical trial for over 6 years, and the device has continued to work after 6 years after implantation. So for those who follow this literature, there is a feeling as if devices that are implanted into the brain stop working after a year or two. And that certainly has not been our experience in this clinical trial. And speaking with colleagues at other clinical trials, also not been their experience with regards to device longevity. There's a small asterisk there, and that is when you go hunting for individual nerve cells and neurons in the brain, that signal tends to degrade after a couple of years. But for solving the practical problem of communication, everything points to the fact that we expect to find ongoing high quality signal that we can use for many years after surgery.
Excellent. Susie shared that she thinks her 70-year-old husband could benefit but doesn't want to have surgeries. And he's also had physicians that have advised against surgery for ALS patients as it could affect the progression. Just kind of any comments there.
Yeah. So the question is, look, I have ALS and I don't want surgery because I'm worried about it progressing ALS. And I'll be frank, I'm not an expert on this. There are many people with lived experience, have one way or another, have seen a progression or not seen a progression after surgery. And that's the kind of conversation one should have with your surgeon as well as your ALS neurologist who's guiding you through the journey of ALS. I will say in my own personal experience, I have not personally seen people with irreversible neurological problems after surgery with ALS, but we're still learning. And my approach to doing this is to be very thoughtful with regards to anesthesia medications, to bring in my anesthesiologist on board for these kinds of conversations, and also have really frank discussions about what could and couldn't happen as part of these operations. It's an excellent question, and I'm not an expert in the field, and I hesitate on commenting too much about the interaction between ALS and anesthetics.
Those were all we had in the chat, but if there's anybody else that would prefer to ask one, you're welcome to unmute yourself, and I'll give a couple of minutes to see if anybody else had any other questions.
One of the most powerful things about this technology that I learned only after I started, Casey's kept using it, was actually about the impact of caregiver burden. And so you can imagine that if the only way for you to be understood is by having someone by your side translating your words, that puts a lot of pressure on the person that's translating. First, because they have to be there. In other words, they're not doing something else like taking care of the home or looking after a child or working. And because they have the pressure of making sure they understood you correctly and also not misrepresenting or mistranslating your words. And one of the most powerful aspects of this technology that I learned only after I saw it in action was exactly what it meant for his care partners and what it meant for him to be able to speak in his own voice.
Fantastic. I have a question. So absolutely incredible that the technology has progressed to the point where you're able to directly decode intended speech. I am curious because a lot of the current communication devices used, whether it's eye gaze or other devices, they're used for a variety of functions. How does this device kind of work alongside some of those other kind of intended functions, whether it's the kind of more of the point and click to do computer access or phone access or some of those other functions?
So I'm going to start answering that question. And I also actually want to load up another presentation that I have handy that actually directly show you a video of what I'm about to tell you. So it turns out as we were doing planning for this particular surgery, we were targeting the speech motor areas of the brain. And we implanted 4 electrodes or 4 microelectrode for a total of 256 shanks into the brain. And we discovered something new with Casey. And what we discovered was that not only did this part of the brain encodes speech-related information, but it also encoded movement-related activity. And what's remarkable is that in Casey's case, he can not only translate his intention to speak into words, but actually his intention to move his arm into a computer cursor movement. And so much the same way that I use my computer by speaking and using a mouse, he uses his computer by imagining moving his arm, or as he puts it, using the force. And we translate his intention to move his arm into command signals that move the computer cursor. And then he can use that as an alternative or an adjunct to his eye tracker that he uses for navigating the system. So I largely use my computer using a mouse and a keyboard, and he largely uses his system by using a computer cursor and also speaking. And so I'm going to go ahead and play a video of him using the system, if you don't mind me. So jump into a different presentation that my colleague, Dr. Stavisky, put together, and just jumping to here. So this is him controlling computer cursor with the thoughts. So that's not as good as I can use a mouse, but boy, it's pretty good. It's not as fast as some of the work that's come out through Neuralink more recently. I think that their first user is able to get on the order of 11 bits per second, which is faster than most able-bodied people can control a mouse to find targets. So that's, in terms of information output, about a third as fast, but it's good enough for him to be able to actually control a computer cursor using his thoughts. And I will say, well, why bother? What's the big deal? Well, if you ever use an eye tracker, you know what the big deal is, right? Because eye trackers often leave many things wanting. For example, they're depending on light conditions, they're depending on the face exposure, they're depending on angles. If you get reshifted in your wheelchair, the eye tracker has to be moved. Some people with advanced ALS have problems with moving their eyes or eye fatigue. So for all of those reasons, eye trackers are a great way to get started when that works. And they're brittle, and this is an alternative in terms of restoring communication that is way more robust than a lot of the reasons that I aforementioned. And most importantly, and I think most humanely, most people like to maintain eye contact when they speak, and it feels very unnatural to have to stare at a screen as you're having a conversation with someone.
That's amazing. It looks like one of our participants had a question about getting into the study at this point. She said that her husband, Jim, was diagnosed and has been a slow progressor, but can no longer speak. And
I want to address that question, but also address a few questions came above it as well. And so, so the clinical trial sites for this clinical trial are focused at the Bay Area, Northern California, or outside of Sacramento and Stanford, Atlanta, as well as the greater Boston area. I will say that the Paradromics clinical trial is starting up later this year, hopefully, and it's going to be based out of Sacramento, Boston, as well as Ann Arbor, Michigan. So that may cover the Great Lakes area. So stay tuned. Matt Wilsey, who's a neurosurgeon at University of Michigan, is going to be the site PI for that clinical trial. As for the other clinical trials, I don't want to misrepresent Neuralink, but my understanding is that I don't know the inclusion criteria with regards to the distance from the clinical trial sites, if they have restrictions there. And I know that right now Synchron is not recruiting, as far as I know, for their pivotal study, but they hope to open up their pivotal study in the next year or two. But again, I know less about those companies, and I would hate to misrepresent them in this venue. But certainly those are the four companies in this space that are most active in the kind of the BCI community, as well as speaking with in ALS engagements. The next question I see there is about side effects. One way to answer that is to say, look, any discussion about surgery really comes down to having an earnest discussion with the doctor and the surgeon who specializes in this kind of thing, and talking about the risks of enrolling in this clinical trial and what your expected intentions are in the clinical trial. And I'm very careful not to say risk and benefits because we don't know the benefits yet. We're still studying them from a clinical perspective in terms of how this technology could be used to help people with paralysis. There are certainly risks to surgery, but there's risks to everything in medicine. Having a wart removed, for example, on your skin has risks associated with it. Just like having open heart surgery has risks associated with it as well. And it's just all about whether or not those risks make sense for you in your particular condition in the future that you're facing, and whether or not it makes sense for you to enroll in a clinical trial. And that's really going to be a personalized decision from person to person. Some people have a very low threshold to get involved with surgery because they've seen how surgery can help people in the past. And some people have a very high threshold to get involved in surgery because they've seen how surgery can go wrong for people or it hasn't had the desired effect. And everyone's different. And then there's a comment about husband Jim diagnosed in 2013 having slow progression of the disease. He can no longer speak and it seems to be a good candidate for this technology. And certainly I would say if you're interested in learning more, just check out braingate.org, and follow the links to be able to shoot us an email and check to see whether or not you could potentially qualify for this clinical trial. All the clinical trial sites are currently recruiting new participants. Any other questions I can answer while I'm here? So maybe I'll close out just by saying that I'm excited for what the future has on hold. We're still learning about how this technology works. It's still early days, so to speak, but I think we're about a few years out from having multiple device companies so that you'll be able to come to a center that does this kind of thing and get a device implanted and hopefully have your communication restored. This is not a cure. This is not making ALS go away, but my hope is that one day ALS will be more livable.
Thank you very much. I have put my email address down in the chat. Also, to remind each of you that if you received the link to this presentation, then you will also get the link emailed to you for the recording of this presentation. It won't be tomorrow. It takes a couple of days, believe it or not, to get it all configured for the YouTube platform, but we will get that information back to you. And I'll mention once again that there are several virtual gatherings that Team Gleason facilitates on a monthly basis. And if you are currently not receiving information about that, but you would be interested, please just reach out to me. My email address is very easy. It's just my first name at teamgleason.org. You can also go on our website. There's a picture of me, and you can click on that, and that'll email me too. So easier than you could ever imagine. Dr. Brandman, thank you again. We are very grateful for you spending time with us today. It was important for us to express what options were available to the community, and you've done that so very well, and we're very grateful. Thank you.
Thank you for the kind invitation. I'm passionate about what I do, and I hope to be able to help people speak that want to speak.